we're going to do in Chapter 24, Psychiatric Emergencies. And this is going to be Advanced EMT and also EMT lecture at the same time. And remember that all of your stuff is going to be due Saturday, 11:59 p.m. That's going to be this chapter. And it is also going to be your Module 3 exam. Both of those are going to be due by that time. So let's get straight into psychiatric emergencies. Of course, we're going to find out our fundamental knowledge and apply thusly. We're going to talk about recognition and assessment and everything else. So just to introduce this to you guys, if you don't know by now, psychological and behavioral crises are definitely a medical condition, okay? This is not something that we should throw shade at. We should not look down on someone who has to take medications for a mental illness that they may have, but also understand that when we are dealing with patients who are undergoing a psychological or behavioral crisis, it may not just be a medical condition, a mental illness. It could be mind-altering substances, such as a drug overdose, or it could be stress, because that can do it too. Stress can do some crazy things. So let's talk about myth and reality. Everyone experiences an emotional crisis at some point. And it does not matter if you hold the record of the worst thing that's ever happened in the class of this 26 people that are online right now. It does not matter. All 26 of us, 27 now, can have the exact same experience and handle it 27 different ways. And to be honest with you, out of the 27 people, depending on what it is, it may not be the worst thing that they've ever experienced. And that's okay too. Just so you know, everyone has something like this. And you don't want to assume, first and foremost, as we're going through this, that you have a mental health illness when you behave in ways that we do discuss in this chapter. Don't make assumptions about your patients either. The most common misconception about mental illness is that if you are feeling bad or depressed, that you must be sick. Guess what? You're not supposed to be happy 100% of the time. You're not supposed to be upset 100% of the time either. There's a balance there. So if you have some days where you're just a little down or whatever, okay, that's justifiable. Other reasons for justifying feeling depressed or down can be loss of a job, divorce, death. There's a whole bunch of different reasons, right? But if it becomes too long-term, then that's something different. Many people believe that all individuals with mental health disorders are dangerous, violent, or otherwise unmanageable. And really, in reality, it's just a really small percentage of people that fall into those categories. So we can't know that until we get there. We can't know that until we talk to these patients. And this is a really important skill for us, for the AEMT and the EMT, to be able to predict whether a person will become violent. Let's define behavioral emergencies, and it's what you can see of a person's response to the environment. Responses can be obvious or they can be unclear. It literally does depend. Most of the time, people respond to their environment in reasonable ways, but then there are times when they're either overstressed or there's something that's just abnormal in the way that they handle things, their expectations or whatever. They just don't adjust well to what's considered normal, okay? So a behavioral crisis or emergency is any reaction to events that interferes with the activity of daily living. So one of those behavioral crises or emergencies can literally be somebody who doesn't take a bath for 2 weeks or a shower. They don't do anything for 2 weeks. And I'm not talking about somebody homeless. I'm talking about someone who lives in suburbia and they have access to water and everything else, but they're so depressed they can't shower. As a matter of fact, that's the first thing that really goes when you have somebody that's depressed. And I'm just bringing that one out to play because that's something that we see a lot. So if it's affecting their ADLs or their activities of daily living, it's unacceptable. It's unacceptable by community standards, the patient themselves, family, all of that. So if there's an interruption, if there's a pattern rather than like an isolated incident, then this could be something more, okay? If you have somebody that's just, I'm going to pause that thought real quick. If you have a pattern of behavior that lasts for at least a month, now we're concerned. Now we need to worry about, okay, is this chronic depression? Is this been going on for longer than a month? If you're going 5 weeks and you've taken 2 showers, we might need to go seek some professional help. Okay. And a person who is no longer able to respond appropriately to the environment may be having what's called a psychological or psychiatric emergency. And that may be, they might show agitation, violence, they may become a threat to themselves or even others. And that's really bad, right? Because if they're ready to take themselves out, you are not a problem. You are just a domino in the way, and they will just knock you down at the same time. Okay. But if you have an immediate threat to a person involved or to others in that immediate area, this is considered a psychiatric emergency. And this is where we need to worry about this violent behavior. Okay. So the magnitude of mental health problems, and I'm just going to read this out and we're going to move on. According to the National Institute of Mental Health, 1 in 5 Americans has some type of mental disorder. There are now, let's say there's 28 people here. That's a few. We've got a few mental disorders in this little place, 5, maybe 6. We'll say 6, just be on the safe side, okay, of us that may have a mental disorder. Hey, I'm going to go ahead and tell you I'm one. I have PTSD. So we'll just go ahead and cut that one on out. But this could be caused by social, psychological, genetic, physical, chemical, or biological disturbances. So this is something that a lot of people have. So let's talk about patho of abnormal behavior. There's a lot of factors. You guys can read the factors, but there's a lot of factors that can produce behavioral emergencies and abnormal behavior or an altered mental status. And you guys can look at this. And I will say sudden grief is a big one. You can have somebody go into psychogenic shock and pass out from bad news. And you see it a lot in Lifetime movies, but when you see it in real life, it hurts your soul. And so there are other ones like later on in life, diseases of the brain like Alzheimer's, they can cause problems. So it's not just something that's like an immediate effect. It can be something that's long term. Okay. Organic causes of behavioral emergencies, such as AMS, and a change in the way a person thinks or behaves. Remember, we're talking about organic is something that's already physically and functionally something wrong with your brain. Okay. It may be a permanent dysfunction causing this disturbance. It could be a sudden illness, trauma, seizure disorder, drug and alcohol, and of course, Alzheimer's, meningitis, things of that nature. Thinking about, you could even have AMS from low blood sugar, lack of oxygen, inadequate blood flow to the brain. That's a lot. And you can go down that road too. Environmental causes can be, hey, they're literally sociocultural experts exerts a tremendous influence on behavior. Think about that. If you are around a whole lot of people, you will eventually become part of that social circle. And then when you are not, when you do something abnormal, that behavior is abnormal, people look up and they're like, well, wait a minute, what's going on here? So that can be stressful too. Substance related causes, you guys understand that, and injury and illnesses, that's another one. Functional disorders, this is one in which the etiology cannot be traced. It's just not obvious where this happened, what happened to the brain. So examples are going to be like your schizophrenia, anxiety, and depression, even though all of these have been around, not necessarily schizophrenia, but definitely anxiety and depression have been around quite a bit. They just don't know where some of it comes from. Like sometimes the etiology is just, they don't know. And then your psychiatric signs and symptoms reflect the body's attempt to maintain its balance in the face of physical stress. So what that means is your body, if you have somebody that is depressed a lot, and I'm not talking about bipolarism, I'm just talking about depression, their depression is going to make them sleep. And so the other side of the brain is going to say, hey, we need to wake up. We need to go do things. I don't feel like doing things. I think I'm going to sleep. And then you're going to say, you're going to wake up again. And you're going to be like, okay, I need to go do things. And your body's going to be like, no, I don't want to do things. Hence why you have people that they'll go 5 or 6 days without a shower. Showering once a week. That's a big thing with people that are like severely depressed. Now, I'm not talking about somebody who's just having a bad day or a bad couple of days. I'm talking about people that are medicated, need to be medicated or something like that. Okay. And then grouped according to the systems that they affect. So depression, you think their whole body is depressed, like they want to sleep, sometimes they'll overeat, sometimes they won't eat at all. It just depends, but it's all packed in together. And you can look on table 24-2 to look at some of the symptoms of those. So let's just go ahead and go straight into our scene size up. Of course, we want to know, okay, thank you, Joel. Be careful. of course, we have to assess our environment because look, if you walk into a house and it is completely trashed and there's not a police officer around, you may want to slowly back out without being seen. Okay. Don't poke the bear, guys. And I laugh because I've been in places like that. My husband sent me a picture of a home once. Of course, the patient wasn't in it. This man threw out the oven out of the house. Okay. The TV, I think, went through the window. The refrigerator was upended, complete trashed. I had never witnessed one that bad in my entire career. And he's showing pictures of this. And I'm like, wow. So these are things that you look for that are really big clues. There are other clues that can be someone who doesn't look up to you when they walk in. Okay. Or when you walk in and you try to talk to them, they won't even look at you. They keep their eyes down. That's another one. So think about your scene safety and the behavioral emergencies that you've seen before and everything that kind of goes together with that. Look at table 24-3 for guidelines to just ensure your safety. And then, of course, we're going to determine our mechanism of injury and nature of illness, form our general impression. Okay, so what's our general impression? Are these guys is this person responding to the environment the way that they should? Are they agitated? Are they aggressive? Are they depressed? Are they walking back and forth like a caged animal? Are they sitting in the corner brooding? What's going on? And then assess the level of danger by using the history, posture, scene, vocal activity, and physical activity. Okay. And you can dive into those a little bit further with table 24-4 in the text. Let me see something on these notes. Pupillary response, if the patient will allow you to get their pupillary response, because you can tell if they're having an altered mental status, if it's drug related or not. And of course, we're going to try to get a CBG on somebody also if potential with an altered mental status. Of course, that's after you have already really checked on this patient and understand what's going on. We're going to always stay alert for our potential dangers and continuing worrying about if this is going to be an unsafe scene or not, because the potential for a violent patient is huge. And if you get the patient in the back of the ambulance and you haven't already figured out that they could be dangerous, you put them in a little box with just you, then now we've gotten an explosive amount of things and you can't go anywhere. So you really want to be understanding before you put them in the back of the ambulance with you, is this patient going to be violent? Of course, we're still going to consider our ABCs and our transport decision, and we're going to investigate our chief complaint big time. Focus your questions on the immediate problem only. And the reason for it is because we don't want to get them off of what's going on. If you have somebody with schizophrenia, they may not be able to answer completely, but they love to get off on a different topic. If you have somebody that's bipolar and they are in their up phase, guys, they love to chase as many squirrels and shiny objects as they possibly can. And they will talk about everything from diamonds to McDonald's extra fries. Okay, I'm not kidding. And so you want to keep them on task, so to speak. So when we focus our questions, sometimes we have to redirect them back to that particular question again. And use your therapeutic interviewing techniques. We definitely, usually when we're talking to patients, we can maybe put a hand on their hand or something like that. But with psychiatric issues, you want to limit your physical contact to these patients because sometimes it can cause a lot of apprehension. So we don't want to do that. And we don't want to act like we're going to threaten our patients or even potentially threaten our patients with the way we use our words. So be very careful with how you answer those questions. One of the biggest ones when you go to your suicidal patients are, how long do you think they're going to keep me? And your answer should always be the same. I really don't know. They're going to have to evaluate you before they make that decision. That's it. And that's a real answer because sometimes they'll go to a hospital and they'll be discharged within 24 hours. Sometimes they go to a hospital and they get discharged 2 weeks later. It just really depends. And you don't want to tell the person, oh, you're going for a 72-hour psych hold, because guess what just happened? They're not going to go with you. So you always tell them, and it's an accurate description. It's not lying. It is 100% the same every time. I really don't know. They're going to have to evaluate you and then they'll make that determination. So these are things that you need to put in your repertoire if you don't have it. You need to write that down somewhere and utilize it every single time. Okay, utilize the surrounding people So if you have family and friends and observers, they may have answers to what's going on already, and go ahead and do that. Be actively listening and be supportive. And then, of course, document their intellectual function while you're doing this. During our secondary assessment and our physical exam, we're just going to look for signs of an organic cause by the patient's behavior. So once again, we're going to go back to that whole pupillary response thing. We're going to go for more of an in-depth look at what's going on. What if it's, like fever can cause an issue? What if there's increased intracranial pressure? What's the skin temperature and condition looking like? All of these different things, okay? And you may want to just look for a potential of toxic ingestion. So there's a lot of different stuff there. And also the secondary assessment may be conducted to provide helpful information, because if you don't know already what's going on, maybe that secondary assessment can help move you along a certain path. And maybe it'll put you in a path that you didn't really know was needing to be gone down. Of course, we're going to vital signs and use monitoring devices to measure and assess oxygenation and circulatory status, of course. Reassess. Not a whole lot of interventions go on during a psychiatric treatment, but you're still going to reassess. We're still going to reassess our vital signs. We're still going to reassess making sure they're not going to become violent towards themselves or to you, and just be vigilant for any sudden change that may happen. Your communication and documentation. Give the receiving hospital advanced warning. Usually when we're 5 out, we'll get the radio up and we'll say, hey, I'm interrupting your facility with blah, 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 blah. And this is what I've done, blah, 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 blah. And 5, right? Sometimes with psychiatric issues, you may want to give them a heads up 10 minutes, 15 minutes down the road, something like that, especially if you have somebody that's potentially violent or that's already become violent in the back of your truck and that you have had to restrain. And in those cases, which we'll get to in just a second, those are the ones that you have to, when you hand off, you really have to have a lot of information on those. And so you want to also document what types of restraints were used and the time that you put those restraints on. So let's talk about emergency medical care. Of course, maintain safety for your patient and for yourself. Always and forever, right? I stress 100% every single time we get on this call that I want to go home at the end of the night. I want you to go home at the end of the night. I want my partner to do the same. And that is my one goal that I will reach every single time. And my next goal is to make sure that my patient doesn't get no further harm to my patient and that they don't harm themselves either. Of course, we're going to place our patient on the stretcher with 5 straps in place because first off, it's legal. It's illegal not to do that. But also you want to put all the straps on for not only their safety, but also for yours. If they start unstrapping, well, guess what? You have a little bit of advance notice if they have to go through 5 instead of 3. Okay. We're going to remain with the patient at all time. We're going to make sure that they don't have any weapons on them. I know we're not cops, but you can ask your patient, like, hey, can you just pull everything out of your pockets before we get in the truck? Thank you so much. Hey, can we lift your shirt just to check? Make sure you don't have any weapons on you. I just want to go home to my family. Things of that nature. Avoid challenging the patient's personal space. We don't want to do that. Okay. We're here to help. And we're obviously not going to be judgmental, but we want to maintain our space and their space. Keep that 3-foot bubble for them and for yourself. Okay, so let's get into acute psychosis. This is a state of delusion in which a person is just out of touch with reality. And there's a lot of different reasons for causing a psychotic episode. Mind-altering substances. Okay, let's go back and think about mushrooms from last week or from Monday, okay? Intense stress. That can do it. You've heard about people saying, oh my gosh, work is so stressful, and they have a complete break with reality. What was it? When the stock market crashed, there were men that were jumping out of windows for the love of all things holy because the stress was so great. They knew they had lost people's livelihoods and they couldn't handle it. That's pretty intense stress, right? Delusional disorders, schizophrenia. Some episodes last for brief periods, whereas others just last a lifetime. Literally. So you have to just understand that sometimes these episodes that they last for brief periods, then they come back, especially like with your schizophrenia. But others, like schizophrenia, it can eventually last up to a whole lifetime where they have complete disorganized thoughts, they're disoriented, and they never get back to who they used to be. And here's schizophrenia itself. It's just a complex disorder that's not easily defined or easily treated. Thank you for not giving me any information at all. Okay, that's just how the brain works. Okay. The typical onset does occur during early adulthood with symptoms becoming a lot more prominent over time. Like I was saying before, they'll start out normal, they're going to have their brief periods, and these are just going to get longer and longer until eventually this is just the person. Okay. Influences that have thought to contribute to this disorder can be brain damage, genetics. It can even be psychological and social influences. So one of the things that you're going to see, or several of the things that you'll see, are delusions, hallucinations, and lack of interest in pleasure, and also erratic speech. So what are we going to do for an assessment? Patients are usually incoherent or they're rambling in their speech. So a thorough examination of the patient is rarely possible. Just understand that the principal objective is to transport this patient in the most atraumatic fashion possible. Okay. And so you want to do coast map. And let's go over this one. And this one's important for you to know. You're going to see this again. Consciousness. What's their level of consciousness? Okay. Orientation. What is their activity? Remember, are they agitated? Are they hyperactive? What's going on in their speech? They may be pressured or it may sound strange. They could be using invented words. And if they are, you need to put that down. Thought. Is it disturbed in progression and content and may even show any of the following disorders like flight of ideas, loosening of association, delusions, especially of persecution. So like delusions of grandeur, things of that nature. It may be thought broadcasting, thought insertion, and even thought withdrawal. There can be some memory factors affected, your affected mood, and even perception. And that can be like your auditory hallucinations are probably one of the most common that you're gonna have. Your management of psychosis, usual methods of reasoning with a patient are unlikely to be effective. In this case, you just do what you have to do. Okay. Use your uncomfortable feelings to help make a tentative diagnosis. The disorganized patient needs some form of structure and you are there to help. Okay. You're going to have to give them directions, completely simple, consistent, and firm. So, in plain language, you're going to tell them this is what we're going to do and this is how it's going to be done. And that is all there is to it. And you continue to tell them over and over again. Non-pharmacological techniques should be adopted in this place. And what that means is, yes, if you feel like you need to, go ahead and get your paramedic backup because they're going to have to administer the sedative or an anti-anxiety drug. And then if necessary, we may have to restrain our patient. Suicide. Depression is the most significant factor that contributes to suicide. And there's a common misconception that people who threaten suicide never commit it. That's not true. It is literally a cry for help. And so you just need to be alert for the warning signs. Table 24-5 is going to give you some of those. And essentially just be alert for, look, if they're just really sad all the time, deep despair, hopeless, start giving away everything that they own, especially like the precious things that they love the most. Oh, here's my favorite necklace. Here it is. Here's my favorite ring. Here's my favorite picture of us together. Things of that nature. Those are the warning signs. Does the patient avoid eye contact? Do they speak slowly? Project a sense of vacancy? Do they have any plans for the future? Because if not, then that's a definite big red flag for me. If you still have someone who's depressed and tearful and they're upset and they're a little hopeless, but they're still planning a trip in a month from now, they're not completely lost. If you have someone that's, I don't know what I'm going to be doing next week. Are you going to work? I don't know. Are you going to XYZ that's normal for you? And they say, I don't know. That's a red flag. Okay. And so even if it's vague suggestions, even if it's presented as a joke, if someone says, I'm just going to go and off myself, that's not cool. That's not okay. But if you suspect suicide might be a possibility, do not hesitate to bring it up. Go ahead and get that out there because the quicker you get it out there and the patient understands you're here to help and you're not there to judge and you're not there to do any of the other stuff, then that patient will open up to you. So there's a couple of things to consider. Remember, if a patient is suicidal, they may be homicidal as well. And like I said, you're just in the way. Okay, agitated delirium. This one is delirium is a condition of impairment in cognitive function that can present with disorientation, hallucinations, or delusions. So that's a lot, right? It's really not, but it sounds like it. So agitation is characterized by restless or irregular physical activity. They're agitated. Okay, that's just the definition. Delirium is not generally dangerous, but if they're also agitated, they may go ahead and strike out, and it could be irrationally done. You may not see it even coming. Okay, so be careful of that. And let's see, if you can safely approach the patient, be calm, supportive, and empathetic. Once again, we're going to limit that physical contact as much as possible, and just be careful interviewing to assess the patient's cognitive function, because some people can literally turn anything around on you, and you don't want to be that person that gets taken the wrong way. Choose your words carefully. Be an active listener. This is the biggest one with agitated delirium. And what does that mean by being an active listener? And I want you guys to put it in the chat box. If you and I are face to face and we're talking, how do I know you're listening to me? Just put it in the chat box. How do I know you're listening to me? I know we don't have cameras on today, but okay, eye contact's one. That's a good one. We can be done in 10 minutes, or we can be done in an hour and a half, or in 2.5 hours. Which one y'all want? Okay, there we go. There we go. Engaged in the conversation. Lindsay, elaborate. Eye movement. Okay, by talking back to the patient. Okay, reintroducing what they said to ensure that you understand what they said. I can understand that. Acknowledgement, that's a good one. Nodding is a great one. Responding to questions. Joel, I thought you went on a call here, sir. Getting on their level. Yes, that's a good one. That's a good one. Okay, what you're doing is you are reiterating to your patient, I understand what you're talking about. I'm here. I want to listen to you. I am fully engaged in what is going on with you. I don't understand what eye movement means, Deborah. Could you go into that a little bit more? So when I am talking to someone, nodding is a big one. I nod a lot. I will up and down or shake my head no or what have you. I try to lessen the, oh, I see. I don't like that because that feels, it's filler words. Like I always say, I feel like that's a filler word. We don't like filler words, right? Eye contact, responding somehow to questions, nodding that, yes, Lindsay, that's so much better. Exactly. Because we want them to realize we're not looking off to the side and barely listening to what they have to say. We are listening. You're gonna pay attention. Even if they refuse with what you say, you could still be with them listening because they heard what you said. They just don't want to do it. That's true too. That's true too. Okay, so mood disorders. The changes in affect are accompanied by other symptoms, and the net effect is to cause a major disturbance in the person's ability to function. Up to 21% of the US population. Okay, but that's what the patient may be doing. I'm talking about, what do you do to ensure that your patient knows that you're listening to the patient and what they have to say, not the patient's behavior. Okay, but we do want to definitely look, if the patient is doing that, then they're not, there is something going on. I agree with that, but the question was different. You're fine. Okay, so up to 21% of the US population will experience a mood disorder such as manic depressive illness or major depressive at some point in their lives. Keep that in mind. 21% of America, that's a lot of people. Okay. Patients who experience either depression or mania have a unipolar mood disorder, but patients who do alternate between those are our bipolar disorders, and they are going to switch between mania and depression. And mania is where you're up and you're doing something, okay? And it could be excessive talking, it could be excessively spending money, it could be out shopping online. What's the other one? Going to the boat, gambling a lot, online gambling, something that causes them euphoria. Another one is multiple sex partners. That's another thing. And so you'll see that erratic behavior during their manic phase. And then on the depressive phase is the exact opposite. They really don't do a whole lot of anything. And so they will go back and forth between those two. And it does affect women much more frequently than men, and it may occur at any age. And it's readily identifiable. if you're around that person, okay? So, moving on. Neurotic disorders. Treating neurotic disorders comes at a substantial price. And what that means is, look, guys, when you're treating these anxiety disorders, generalized anxiety disorder, there's so many different things that these patients have, the different cocktails of medications, the behavioral treatments, cognitive behavioral treatment that they may be going through. CBT is a big one. Counseling, always counseling. Sometimes it's once a week. It's once a week with one person, and then they have group therapy. There's a lot that goes into neurotic disorders. So these patients can tell you quite a bit of the things that they've done and what they're doing for themselves. There's also phobias, and those involve an unreasonable fear, apprehension, or dread of a specific situation or thing. Agoraphobia, leaving the house. If you've not run on agoraphobic before and they're having a heart attack, trying to get them outside of the home is almost impossible. I had to call med control and get permission to sedate the patient to get them to leave. And as soon as we got them in the back of the ambulance, they started waking up. And then we got to the hospital. It was really bad. There are a tremendous factor of things that happen. And by the way, the only reason we were able to get her out was because she had an altered mental status. But because we're going to talk about consent in just a minute. But if a person is agoraphobic and they don't want to go anywhere and they're 80 times 4 and they can answer all of these questions correctly, they've not had any illicit drugs or alcohol on board, you got to leave them there no matter what's going on, right? But anyway, but people can have phobias that are so unrealistic and so unreasonable that it becomes a danger to them, okay? Then there's panic disorders, and that's characterized by sudden, unusual, unexpected, and overwhelming feelings of fear and dread, accompanied by a variety of other symptoms. And some of those can be like, they can have chest pain, they can have hyperventilation syndrome, they can have a drop in blood pressure, they can have, oh man, there's just so many different things that can happen with these people. So just be ready for anything. And it even says may mimic a range of physical disorders in their presentation. It really can. And people find different ways to handle their panic attacks. One woman that I used to pick up all the time, she would raise her hands above her head and lay back on a couch, or she would lay on a like kind of across a table almost, or if she had stairs, she would lean against the concrete stairs in front of her apartment. And she said it helped open up her chest and stopped her from breathing rapidly, and it stopped her chest pain. Hey, this helps her. That's fine. I'm not going to stop it. Okay. Because she had a severe panic disorder. And so you will find people that are like that. Now let's talk about our medico-legal considerations, because this is where we're going to get into some questions, right? They're more complicated with a patient undergoing a behavioral crisis or psychiatric emergency. And as such, they should be, right? Legal problems are reduced when the patient consents to care. But gaining that it's not hard. So you may have somebody that's okay. So hey, mental capacity can be can take many forms, including the unresponsiveness. Let me read that. Mental incapacity, unresponsiveness, temporary but severe stress, depression. There's some other stuff there. Okay. And keep in mind, when a patient is unresponsive, we may not even be talking about a psychiatric patient. This may be because of trauma. It could be hypoxia, drugs, hypoglycemia, stroke. The list goes on. But in this particular case, we're talking about some sort of psychiatric reasoning, right? Once you've determined that a patient has an impaired mental capacity, you, the provider, the EMT, the AEMT, you must decide whether he or she requires immediate medical care, emergency medical care. If a patient is has a mentally unstable condition, they may resist your attempt to provide care. You cannot leave them alone. That's called abandonment. You can lose your license. You can lose your certification. Don't do that. And you don't want to be negligent or anything else, right? So in situations like this, go ahead and get your law enforcement in to help you and get them whatever the case may be, okay? In some cases, you may have to get a paramedic en route to help you if you think that this patient's going to be violent, things of that nature, okay? So let's go back over consent. Implied consent is assumed with a patient who is not mentally competent to grant consent for emergency medical care. Examples are, and I'm just going to read from the notes, the consent of an unresponsive patient is implied. The law refers to this as the emergency doctrine. The emergency doctrine is consent is implied because of the necessity for emergency treatment. So this is an obvious thing. They're having a mental breakdown. It doesn't matter if they beg to say, if they beg you, no, I don't want to go, please don't make me go, or if they're being violent, it doesn't matter. If they are not okay, we have to make them okay. Go ahead and put the monkey on the back of the med controlled physician, or just go ahead and follow your local protocols when there's any doubts. Consent matters are not always clear cut, especially when we're talking about psychiatric emergencies. Is this patient in a life-threatening emergency or not? So you have to be the person that decides that factor. And you also better document it. And you better have, well, it better be more than just, okay, I have a gut feeling. Okay, did the patient say something? Is there a couple guns laying around that they're freshly loaded? Why do you feel like this person is in a life-threatening situation? And if you're just not sure, go ahead and get law enforcement en route to help. Okay, so limited legal authority. Patients do have the right to refuse care. Most states have a legal statute regarding the emergency care of mental ill and drug impaired people. Check yours. A competent adult has the right to refuse treatment, even if life-saving care is involved. I've already gone over that before. When in doubt, go ahead and call your supervisor, police, med control, put the monkey on somebody else's back, especially med control at this point, because you know what? They've gone to school for years. They're in the med control arena for a reason, okay? Let them make that deciding factor. And of course, call your supervisor if you need to. Call the police for help, okay? Err on the side of treatment and transport for everyone, every time. Restraint. This one, when I first started in EMS, it was not a big deal to restrain someone. It was perfectly fine. As a matter of fact, when I came into EMS, they had stopped sandwiching people between two backboards and putting them in the prone position because that was killing people. It was causing asphyxiation. And literally, I came into EMS at that point in time when that was like, people realized you're doing something bad. So restraining a patient just normally really wasn't that big of a deal. Now, on the other hand, restraint is a big deal. If you restrain a person without the authority in a non-emergency situation, you're opening yourself up for a lawsuit and a whole bunch of other stuff, okay? You can be hit with assault, battery, false imprisonment. You can have a violation of civil rights, whole bunch of stuff. So make sure when you use restraint that you are using it for a good reason. Use restraint only to protect yourself or others from bodily harm. That's it. That's the only time we're going to do it. You're restraining them to protect yourself or others from bodily harm, okay? You may only use the reasonable force necessary to control the patient also. And so it depends on the courts on which one they decide, right? Involve law enforcement to assist in severe behavioral or psychiatric crisis. In subduing a disturbed patient, use minimum force necessary. We're not trying to break bones here, guys, okay? Yeah, Mama may be a lot stronger than her 98 pounds looks, but we're not trying to break her arm, right? Okay. And have and document witnesses in attendance. Get their names, get their phone numbers before you leave, okay? If the patient is spitting at you, just place a surgical mask over their mouth, okay? And I'm going to tell you, I know this is hard pressed, but this is in the book and it could be on National Registry. If you have a patient that has been restrained, you need 4 people to carry that person out, okay? One person each has to be responsible for each extremity. And so that's another thing that I want to talk about there. All right. And of course, after you've restrained a patient, we're still going to check for pulse motor and sensation in all 4 limbs. And we are also going to make sure that they can breathe well, their ABCs. We're going to do their ABCs essentially. Okay. And you're going to have to continue doing that. All right, PTSD, moving right along. This can occur after an exposure to or injury from a traumatic event, and there's a lot out there. The reaction could be trauma that occurred a long time ago, could be multiple traumatic events over time. And you know what, guys, we really don't have to sit here and figure out what kind of PTSD there is, and they're coming out with more and more different types of PTSD as the days progress because they're finding, hey, there is one for military, But there's also one for police officers. There's one for EMS workers. There's one for firefighters. There's sexual assault PTSD. There's PTSD for a lot of different things. So we don't, yes, we care, but the treatment is the same no matter what it is, right? Um, and the signs and symptoms are the same no matter what it is. You have a feeling of helplessness, anger, anxiety, rage, fear. And guys, this will mess with this nervous system arousal. So it changes with your fight or flight response. And instead of being able to cut that off, these people are in a fight or flight response all the time. And so they jump all the time when there's like a loud noise that they're not expecting, or an exaggerated response to things. And yes, Mark, exactly. The triggers are different for each one, but in the same aspect, there are triggers for each one, even though they're different. Heart rate, dilated pupils are heart rate's increased, blood pressure is increased, rate, depth, and quality of the breathing is increased, pupils are dilated, and their mental acuity is also heightened. They are never shutting off. And so when they have these intrusive thoughts and nightmares and flashbacks, because of the amount of adrenaline running through their system, they literally are there when they have these flashbacks, when they have these nightmares, and when they have the intrusive thoughts. Sometimes they can even, that's something else. You also have like dissociative PTSD, and that occurs when the person attempts to find an escape from constant internal distress or a particularly disturbing event. You can have guilt, shame, paranoia, hostility, depression. Those are not uncommon. And of course, high cholesterol and hypertension, because when your blood pressure and your heart rate stay as high as it does with people with PTSD, that's what happens to you. People with PTSD, what's the word? Cortisol. The stress hormone is way high in people like this. And so that causes higher cholesterol, which causes atherosclerosis, and then of course, hypertension. And so these people die from heart attacks a lot quicker than other people. Anyway, I went off on a tangent there that was more for paramedics than advanced EMTs or EMTs, but it is a thing. So, caring for combat veterans, when treating a combat veteran with PTSD, try to eliminate excessive noise. Turn the TV off, turn your phone down, turn the radio down rather. Turn your phone to silent, things of that nature. Try to pull all of the outside noise, pull it out. Just go away. Don't let it happen. Okay. This is they're going to get heart disease maybe a little bit earlier in their age. They may even have a higher incidence of type 2 diabetes, but they have a loss of brain gray matter over time also. There's a unique level of understanding, compassion, and specialized attention that is required to go ahead and take time to establish that history for the patient and be sensitive and respectful naturally. And be careful how you phrase your questions, obviously. Okay, so now I'm going to turn this one off. Thanks, guys, for watching the replay.